Welcome to today's webinar. We'll be starting shortly. Today's webinar is the new normal. We'll be starting in just a few minutes. Health Choice Network and Alliance Chicago, preparing communities for COVID-19 and beyond. Today's webinar will be about the new normal. Where are we today? The webinar will be starting in just a few moments. In preparation for today's webinar, please join us with our word cloud. Take out your cell phone, text in 22333, and then put in COVID-19 heroes and join in our word cloud. Today, what aspects of the new normal am I looking forward to? Please join us in our interactive word cloud. Our webinar will be starting shortly, preparing communities for COVID-19 and beyond, the new normal. The webinar will be starting shortly. Please get out your cell phone and join us for our interactive word cloud. Type in 22333 and put in COVID-19 heroes, and you're all set up to join in our word cloud for today. And here's our word cloud question for today's webinar. What aspects of the new normal am I looking forward to? Please join us in our interactive word cloud throughout today's webinar. Our webinar will be starting in just a few minutes. We're inviting you to Better Together, Innovating Now for Tomorrow, Health Choice Network and Alliance Chicago's joint conference coming up in the fall. But today, preparing communities for COVID-19 and beyond, the new normal, will be starting in just a few moments. Get out your cell phone and join us for our interactive word cloud. Using your cell phone, type in 22333 and then put in COVID-19 heroes, and you're all set to join us for today's interactive word cloud. Our question today is, what aspects of the new normal am I looking forward to? The webinar will be starting in just a few moments. Better Together, Innovating Now for Tomorrow, Alliance Chicago and Health Choice Network's joint fall conference. More to come. Today's webinar, Preparing Communities for COVID-19 and Beyond the New Normal, will be starting in just a few moments. As we prepare to start the webinar, please take out your cell phone and type in 22333 and then put in COVID-19 Heroes in the text line. And then join us in our interactive word cloud for the day. For today's webinar, what aspect of the new normal am I looking forward to? We will be starting the webinar in just 1 minute. So good afternoon and good morning to some people on the West Coast and in Hawaii. Thank you for joining us today on series number 10 on COVID-19. We're glad that you could join us today because we're jumping into a new area of the new normal. And today's word cloud, we want to hear from you. Type in 22333 and let us know what you're looking forward to in this new normal. But Health Choice Network and Alliance Chicago in Action are preparing communities for COVID-19 and beyond. Today's theme is the new normal. Where are we today and how are we doing it today? As we move forward, we're going to look today at our agenda. We'll have a few minutes of welcome. Then we're going to hear from our CEO updates. We'll hear from Dr. Fred Rockman of Alliance Chicago. And then we're going to hear from a number of health centers who are going to tell us about their experiences in this new normal. The new normal is something that we're all in, and we don't know where we're going to end up in this new normal. But beloved Community Family Wellness Center, Erie Family Health Centers, and Howard Brown Health Center are going to let us know where they are in this new normal. So as we move forward, let's hear from one of our CEOs at Alliance Chicago, Dr. Fred Rockman. So Fred, are you with us today?
Yes, I am, Tim. Can you hear me?
Perfectly, Fred.
Great. Hello. On behalf of Alex and the Health Choice Network and Alliance Chicago teams, I want to thank you again for joining us today. It's great to be back on the call with you all. I have learned so much from you and have taken so much inspiration from your stories over these past calls. Honestly, the calls have played a really big part in my personal journey over the past few months. As Tim said, on today's call, we're starting to take a forward-looking perspective, drawing on what we've experienced and learned together. As I reflect on the past few months, there have been some themes in our collective experience that can begin to inform how we think on defining a new normal. So certainly, we've rapidly expanded our thinking about where and how we can deliver care, how we adjust care provision to the circumstances and needs of our patients. We've learned a lot about how flexible we can be. We've had to better understand, I think, our patients' circumstances since we've had to interact with them more on their home turf, and to understand and cope more directly with the limitations of their physical and social environments. I think we've begun to understand more clearly the relationship between personal and community health, which is where I think we come from, and what we previously may have thought about as solely public health system responsibilities. All of these begin to frame new opportunities for us for growth and improvement going forward. As Seema Verma said, it's impossible to think of going back. COVID-19, I think, has also been a lesson in the need to attend to our own stress levels and needs. we're suddenly all impacted along with those we care for. We have had to define new support infrastructures for ourselves and our patients and communities. This past week, I learned of a study done by Healthcare Ready annually to evaluate attitudes and preparedness of diverse populations for natural disasters. If you're not familiar with the work of Healthcare Ready, I highly recommend you look at their website. Not surprisingly, in their survey, the disparities are stark. We can expect going forward that the long-reaching economic impact of the COVID-19 and the last few months will make our jobs both more significant and challenging for our patients and communities. And I think this is especially true if we view our role not only as addressing the immediate impact of the virus, but as dedicating ourselves to primary prevention and the health of communities looking forward. And if we share responsibility for our collective resiliency to recover and withstand future emergencies. Just as we all begin planning for what we hope is a long, slow recovery phase from the acute public health threat of COVID-19, the deaths of Ahmaud Arbery, Breonna Taylor, and George Floyd suddenly demanded our attention to another, more insidious and chronic public health threat, that of longstanding racism and structural violence. As we begin to reinvent our future, I hope we're all resolved to become more deliberate in addressing this larger problem. It's a social determinant of staggering significance and one that requires us to work together at scale. That responsibility certainly weighs heavily on us at the network level. I'm looking forward to today's discussion about how we're contemplating the path ahead and counting on new insights and ideas. Let me plant the seed that we think about how to bring the same sense of urgency to our convening as a community around COVID-19 to the deeper, more pervasive and chronic threat to our public health represented by racism and structural violence. So thanks, Tim, for your leadership. Back to you and today's panelists.
Thank you, Fred. As always, we appreciate your calming words that allow us to embrace change and experience growth into the new normal. So again, thank you, thank you, thank you. So as we advance the slide, we're gonna have a little interaction here, and it's gonna be our first of a few polling questions. So here you'll be able to poll right on your computer, whatever device you're watching this webinar today. And our first polling question is, in the new normal, what % of office visits will be conducted using telehealth? First would be less than 25%, then maybe approximately 25%, 50%, 75%, or more than 75%. So we're going to switch over into the actual polling, and here you go. Please use if you're on your computer, you can use your computer mouse and click on this. If you're on your cell phone, I think you can click into the poll also. We're going to give it a few minutes while we allow, actually we had 500 plus registrants for today's webinar. So I don't think everyone will be participating in all of the polls we have for you today, but we'd like you to. So in the new normal, what percentage of office visits will be conducted using telehealth? And here are your selected answers. Please select one of those. And as we go, here are our results. It looks like the 25% range and the 50% range are the two highest responses. So this is a great variety, which will allow us at Health Choice Network and Alliance Chicago better to help you in planning your new normal and beyond. So it looks like at least 25% to 50% of visits, office visits, will be used with telehealth. So thank you very much for your response in that quick poll. And now I'd like to turn to one of our colleagues in Chicago, beloved Community Family Wellness Center. And first we'll hear from the CEO, Margie Johnson. Margie, are you with us today? And we're going to give it just a minute. Yes, Margie, hello. Perfect.
Can you hear me? Okay. Yes. Well, thank you again for allowing Beloved to participate in this session, The New Normal. I have two staff that will also present. Dr. Catherine Wilbert, our high-risk OB physician, and Nita Marchant, our behavioral health program manager and certified alcohol and drug abuse counselor. They will present following me. Next slide. Getting health center staff back to work. At Beloved, staff that was laid off due to COVID-19 guidelines have returned to work. Some individuals, based on age and medical conditions, were informed by their physician that they should not work due to being high risk, have retired. And work accommodations were made for returning staff to lessen their chance of getting the virus, such as reassigning office space, installing desk, table, sneeze guards, educating and training staff on the importance of wearing masks, gloves, gowns, and face shields, and distancing office guest chairs to ensure safety for all. Next slide. Some of our operational hours have been restored as patient demands require it. In the beginning, we did reduce our working hours due to less face-to-face patient visits and more telehealth. Personal protective equipment is mandatory and is available to all staff based on what it is that you need. Social distancing is practiced and appropriate areas have been rearranged to accommodate. Some positions were repurposed, staff trained to help support COVID-19 and to assist with care coordination activities. Next slide. Telephonics and video patient care is a part of the new normal for us, and I do expect for this to continue. We have new and revised policies and procedures that have been implemented to improve safety and patient care services. All returning staff receive in-services and training on protocols for entering our building what our new workflows, new dress codes, and telehealth services were. As new symptoms and guidelines are identified, all staff are informed and trained. New symptoms are added to our health questionnaires when screening for COVID-19. Next slide. Getting our patients back into the health center. In the new norm, we have incorporated face-to-face visits, telephonics, and video patient visits, and we are expecting for this to continue in the new norm. Patients and visitors are informed of our new safety, service procedures, and process for entering our building at the time that they schedule an appointment or when they are seeking information. It is important to us that we decrease fears. It is mandatory that all individuals wear masks, and if they don't have one, we will provide one for them. Next slide. We have 2 mobile units that are in our parking lot to provide screening and testing. One is for screening, and the second one is for individuals who may answer yes to symptoms. If they answer yes to symptoms, we take them to our second mobile unit where a physician will do a more detailed assessment. And based on that, the next steps will be determined. Next slide. Patients are educated on the importance of social distancing. Our waiting area has been rearranged to accommodate social distancing, and this is practiced throughout our health center. Information is also posted on our social media to keep our patients and community informed and updated on COVID-19. How to access our services for screening and testing, and what our services are in general. Patients' guidance on returning to work. Patients are educated on making sure they understand what their work environment will consist of upon their return, including safety precautions. They are informed about understanding their employer's back-to-work processes and what is required of them. And we educate them on the importance of wearing a mask, washing their hands often, wearing gloves, and to practice social distancing in their work environment. Next slide. Patients are encouraged to speak with their providers immediately if they feel ill, no matter how insignificant this may be. We provide our patients written guidelines to follow to help keep them healthy and encourage them to call their providers if they have questions. And all of this information is posted through our social media. We believe the steps that we have taken allow us to work better in the new norm, and we make adjustments as needed. This ends my portion of our presentation, and Dr. Wilbur will now present OB/GYN in the new norm.
Good afternoon, everyone. Can everyone hear me?
Yes,
Can everyone
perfectly.
hear me? Okay, hi.
Yes.
My name is Dr. Catherine Wilbert. I'm a fellow of the American Congress of Obstetricians and Gynecologists, and I'm the OBGYN at Beloved Community Family Wellness Center. My first slide is showing going upstairs because it's pretty much an uphill battle with changes that have occurred during the pandemic with obtaining health care for our obstetric patients. And many problems and effects of the virus are still not yet known, and how women are affected and their fetuses are affected by this virus. The maternal morbidity and mortality internationally are viewed as indicators of the overall health status of the community. And in the U.S., maternal mortality is 3 to 4 times higher than in other nations. This epidemic existed prior to the advent of the pandemic. As you'll note by the slide, the IDPH, Illinois Department of Public Health, their first morbidity and mortality report in 2019 came out in response to an all-time high of 93 deaths of women related to the time surrounding pregnancy in the state of Illinois. Prior to that time, or just prior to that, in 2008 to 2016, the average was 73 women per year dying with pregnancy-related conditions. Black women are currently 6 times more likely than non-Black women to die during or immediately after a pregnancy or in the first year, and this is regardless of social economic status. Next slide, please. As noted, prior to the pandemic, many OB units in the areas affected by this maternal morbidity and mortality have closed. At Beloved Community Family Wellness Center, I've outlined the distances for many of the hospitals that are remaining that have OB units available. And St. Bernard Hospital, in response to being overwhelmed with the COVID-positive patients, closed the OB unit April 20th of 2020. It was 1.2 miles away and only 5 minutes away. And there's a little bit of a distance. A lot of patients are being taken by ambulance to Mercy Hospital. However, some patients have expressed that that's too far and they cannot get there, or they are now, with restrictions from the hospital, are only able to come in and labor, and they're having only one visitor. There are a lot of restrictions due to the pandemic. In addition, patients need some forms of testing depending on their risk profile, and many of the institutions require prior authorization to get the patients seen in a timely fashion during their prenatal course. Next slide, please. Distance is not the only factor. Patients have quoted the quotes from the patients on the left. I'm trying to go for my high-risk referral appointments, but I don't have a way there. Or I don't have child care for my children, because I used to be able to take my children with me if I went for an appointment, but I cannot take children now, so I don't have child care. They're concerned because their mother or grandmother who may be in a high-risk group should not be, in order to maintain social distancing, the child care of the village has changed for these patients. There are visitor restrictions at medical facilities, and some patients have even expressed the desire to try and labor at home, even if they're in the high-risk category, because they're concerned about exposure to COVID-19 at the hospital. Next slide, please. There are alterations or delays in care that have occurred. As I stated, prior authorizations are needed from insurance companies if patients are now considered out of network. There are non-timely appointments with a lot of the hospitals, and we're unable to schedule antepartum testing urgently. Patients cannot be referred. They have to present to the hospital as a walk-in. I myself personally called many of the facilities that are remaining the week that the St. Bernard closed, and was told that, patients have to come in as walk-in patients. So even if they've had prenatal care, if they have high-risk problems, they're not able to get timely referrals. So what we've done is we've tried to change a lot of those things or anticipate ahead of time what services patients will need. Our goal is to decrease maternal morbidity and mortality despite the pandemic. Next slide, please. Our new normal. COVID testing is available for all patients at Beloved Community Family Wellness Center. We are substituting telehealth visits when appropriate per ACOG guidelines to decrease potential exposure. We've ordered blood pressure cuffs for high-risk patients for home blood pressure monitoring. We've assisted patients with getting enrolled in patient portal so that they can communicate more directly with me regarding any concerns or blood pressures or home glucose monitoring. They are being provided with sheets of paper that include lists of which hospitals take which insurances so that it's not a surprise when the patient goes into labor. She already has her hospital identified early in the pregnancy. And we're working with individual health plans to streamline maternal referrals. Other possible community solutions might be a collaborative referral process for community health centers with remaining hospitals. Patients' records should be available when presenting in labor. There's a higher margin for error and complications during the delivery admission when no records are available. And it might be nice if we could get statewide funding earmarked for safety net hospitals to subsidize maternal care. Particularly, we are dealing with two epidemics and pandemics. We're dealing with maternal morbidity, mortality increase, and we're also dealing with COVID-19. So it would be nice if we could get hospitals to subsidize maternal care, possibly leading to reopening of closed units. Thank you very much for your attention. I would like to next introduce Nita Marchant, who is the Behavioral Health Program Manager, speaking about Beloved's new norms for behavioral health care services. Nita?
Thank you, Dr. Wilbur. Thank you, Ms. Johnson. And thank you, audience. I am very happy to be a part of this process. So I want to emphasize here at Beloved, we are emphasizing a holistic and integrated approach to COVID-19 recovery. So an overview of our approach, just to speak of the goals. Our goal is to educate and counsel patients on how to manage behavioral and mental health challenges during and after COVID-19 pandemic. First, we let our patients know there is no need for shame. No matter the root causes, behavioral health challenges, including mental and substance use disorders, are health problems, just like cancer, arthritis, or diabetes. But with what's going on with the COVID-19, it demanded our attention, and we had to immediately address the staggering, disproportionate COVID-19 pandemic death tolls that reached 72% in marginalized communities of color. Knowledge of the high mortality rate places the population at immediate risk of elevated behavioral and mental health challenges. Here at Beloved, we took immediate action to develop and implemented integrated, holistic, and trauma-informed measures to address the new norm practices recommended by CDC. Next slide. What did we learn and observe here at Beloved? Overall, according to the United States Department of Health and Human Services, through a SAMHSA report, we learned that vulnerable people of color are at risk of heightened mortality rates during COVID-19. That was confirmed through this study. Things that contribute to this problem include escalated periods of anxiety, depression, and other behavioral mental health disorders. Additional issues that place this population at high risk include the following. Number one, the population has higher rates of underlying health conditions such as diabetes, asthma, hypertension, and obesity compared to other non people of color. Number two, that we're more likely to be uninsured and to lack a usual source of care. Number three, we're more likely to work in the service industry, such as restaurants, retail, and hospitality, that are particularly at risk for loss of income during the pandemic. Number four, more likely to live in housing situations, such as multi-generational families or low income and public housing that make it difficult to social distance or self-isolate. Number five, this population often works in jobs that are not amenable to teleworking and use public transportation that puts them at high risk for exposure to COVID-19. Next slide. So what do we do about this? What are we doing here at the Beloved? What is our response? First of all, we understand that barriers to behavioral and mental health care in marginalized communities of color are a direct result of historical problems associated with oppression, racial discrimination, stigma, fear, profiling, and conspiracy theories. So to reduce these barriers, here at Beloved, we implemented several evidence-based practices with a racially diverse chronic health care team of clinicians that include medical directors, medical doctors, registered dietitians, LCSWs, chronic care nurse, and a certified dual diagnosed substance use and mental health disorder counselor. That's my specialty. So collaboratively, the team developed and implemented a new norm of holistic, integrated, and trauma-informed patient care. At the end of the quarter, in May or within 1 month period, here are some of the things that we noticed. First and foremost, what we started was a virtual video COVID-19 education outreach program via Facebook Live and Zoom. This increased, we noticed that there was an increase in page views from 162 to 322, and there was an increase in video page views from 1,039 to 4,312. I want to expound on this, so this is a little bit more. The new norm adopted during the COVID-19 was designed to stay connected with patients and encourage them to return to the clinic for medical and mental behavioral health care on a regular routine basis as needed. Our main focus was coping with COVID-19 blues. The theme, reinventing and caring for self, family, and the community during and after COVID-19 pandemic. The presenters where we had panel presentations with our chronic care team that I just mentioned above, and the topics, some samples of the topics that we covered were managing chronic health conditions during the COVID-19, managing triggers that weaken your immune system, such as fear, depression, anger, anxiety. Another example was living in balance through cultivating a new healthy lifestyle that addresses physical, mental, and social environmental well-being while practicing social distancing. Last two things I'd like to bring to your attention are the new norms, our new norm challenges. So here we would notice that patients have limited access to and use of virtual technology. Some people don't even have for instance, a cell phone. Some people don't know how to use it. So then another barrier or challenge is the ongoing challenges with reducing social and economic disparities relevant to general health and wellness. The new norm benefits, what we've noticed here in our environment. We are developing an ongoing cultivation of family-oriented services, super clean environment, and culturally competent staff of providers who demonstrate genuine care for patients' holistic well-being. And that ends my presentation. I thank everyone for listening. I'm going to turn the mic back over to Mrs. Johnson and be prepared for any questions that may be out there.
Well, I'm going to turn it back over to Tim. Thank you all for allowing us to present, and we want everyone to know that all of the sessions that have been had have been very informative and educational for us. So we're glad to be a part of this.
Yes, we are.
Thank you.
And thank you, Margie, and thank you, Beloved team. We're so impressed with not only this presentation, but all the work that you've been doing, and this is a very challenging time for everyone. So thank you very much for sharing your stories and your experience with us.
You're welcome.
So next
You're welcome.
we're going to do thank you. So next we're going to turn into another poll. So hopefully you're able to join us in poll question number 2. I'll read the poll and then we'll get into the actual responses. In the new normal, which services will be offered via telehealth? And you may select all that apply. There's 5 options. We can only do 5, so that's why there's 5. But if we turn over to the actual live poll, you can give the response. So the quick poll is, in the new normal, which services will be offered via telehealth? So during this new period of the new normal, are you planning on offering dental, behavioral health, adult, pediatrics, women's health, which includes both women, gynae, and OB? And you can select all that apply. So we'll give you a moment to respond to our quick poll of the new normal and services that would be offered in your health center using telehealth. So, Stephanie, why don't we turn the poll over and see the immediate results? There we go. Looks like 97% will be offering behavioral health during this new normal. 89% will be offering adult medicine services, so that includes internal medicine, family medicine catering to adults. 70% have pediatrics, and women's health, which includes women, gynae, and some OB at 46%. And then rounding it out at dental at 34%. So excellent, and thank you very much for that quick poll on the new normal. So next we're gonna head across town in Chicago to Erie Family Health Centers, and we're gonna hear from Amy Valukas. Amy, are you with us today?
Good afternoon, hello.
Hello, Amy.
Hello. So thank you, Tim. Thank you to the Alliance and HCN for bringing these learning communities together. They've been incredibly powerful in this moment of rapid learning. And I just have to say that it's a hard act to follow. The beloved team, that was really, really a fantastic presentation. So thank you. Just a little context for Erie Family Health Centers. We are a community health center serving the greater Chicagoland community with a focus really on the northwest sides and the northern suburbs. We do serve a lot of moms and babies, a highly maternal child-based population. We do about 2,700 deliveries a year. And the majority of our patients are best served in a language other than English. That has traditionally been Spanish, but it is a growing range of languages, and we serve patients in over 70 different languages. I remember on March 15th when my chief clinical officer called me on a Sunday morning and said, it's time, we have to blow all of this up. And our leadership team met that night, and we blew up our schedules, and we called all of the patients, and we moved to a well model and a sick model. And those first few weeks, we saw about 30% of our regular volume of care. And we moved to many in telehealth and deferring a lot of care. And it was hard. It was hard for the teams, and it was hard for patients. Patients weren't seeing their PCPs. Care teams were not together serving the usual patients they were seeing, and folks were confused. Next slide. To support all of this, I wanted to note the incident command structure we did put in place, because I think it continues to demonstrate just the complexity of these moments and the complexity of eventually what our patients experienced. This is what Erie put in place in about 2 days. You can see a lot of this really is focused on how we connect to patients, how we help patients understand what is going on and get them back into care. I will say these teams met daily, 7 days a week for the first month or so. And most of this early on was solely focused on infection control and patient and staff safety. So a lot of our traditional model of care really disappeared, like everyone else. It also left people, both patients and staff, exhausted. And so with that, next slide. In mid-May, by then we were at about 90% patient volume and seeing about 70% of our care through telehealth and about 30% in face-to-face. We knew that we needed to start shifting back to the new normal. And so we sat down to really set an intentional plan for this. And actually we really launched this new plan this past Monday, June 22nd. And first, we wanted to set our priorities for this new normal. And of course, patient and staff safety continued to be the highest priority, along with really making sure patients and staff felt confident in that. So communication was a huge part of this. I can't tell, our entire staff knows the OSHA hierarchy of controls. They know what type of HVAC filters we're using. They know how we've changed the air intake. We really try to communicate all of this in extreme detail. But we also wanted to go back to focusing on continuity of care because it was important for quality, and it was also important for our patients and our care teams. And so we wanted to make sure we were aligning patients with their PCP, that we were able to find ways to ensure patients received their preventive services. And we wanted to stabilize our schedules. We knew that our schedules, with all of these changes, had become much more fluid than we typically have, which made it harder for patients and staff to really plan for their time, to know what was going to happen with their day. So we knew we had to stabilize that. And all of this at its core, communication, was really what allowed us to do all of this. Noting the graphic here, one of the things we did was really kind of identified a campaign that is a visual theme for everything we'll be doing to promote social distancing, to promote all the various COVID safety measures for patients and staff. Next slide. So as I noted with this, this was confusing for our patients. And in those first 2 weeks, we saw about 30% of our typical patient volume, which is obviously a tremendous business impact, but more importantly, means that our patients were not getting their needed care. And this was highly concerning to us. We also knew that with our visit volume so down, we had some staff capacity. And with that, we really worked to be intentional in how we outreach to patients. We knew we had to stay in contact with our patients, but what we needed them to do wasn't the same for each patient. So we really started by developing teams and to address certain parts of patient outreach, and we looked at that really broadly, so more of a marketing approach, and then we looked at a population health approach, and then we also wanted to make sure we were thinking about some of the other issues impacting our patients, those social determinants of health. To be able to do this in a thoughtful way that didn't cause downstream challenges, we really wanted to start with the data. We wanted to see how many visits do we have and where do we have gaps. We wanted to see how much we were doing by telehealth versus face-to-face and what kind of care could we do in both and how do we fill those gaps. Of course, our quality metrics were huge. What things were falling off in this? What kind of care were people not getting? And while we felt like we knew, it was important to look at the data to really understand this and really looking at who was falling off. And not shockingly, for us, this was a PEDS issue. Of course, it was across all of our patients, but in particular, we saw an incredibly dramatic impact in our peds visit volume. And some of this was intentional. Those first weeks, we told, well, peds, you should not be coming on site. But then how did we re-engage? We also needed to think through, what did we want patients to do when we engaged with them? Did we want them to come in? Did we want them to have a telehealth visit? Were we just checking in on them? So really assessing by each patient population what it was that we were going to ask them to do with that outreach, and then what were the operational impacts to any of this? Where did we have capacity or need to fill schedules? What was the impact on call center? Those kinds of things. So with that, we developed a strategy for patient engagement that really follows through now to this re-engaging of patients. We started with patient emails because those were easy, they were quick, and we could get a good amount of information out there. We also know that not all of those get read. We have emails for about 60% of our patients. They were everything from explaining how telehealth worked to reminding them Erie was open for them. We did direct mailing. I can't remember the last time we did direct mailing to our patients. It was noted to us that very little mail is going out right now. And so we did a mailing to all of our households, reminding them that Erie is still here for them and explaining telehealth. We sent texts to targeted texts and to all patients. And those were both, again, about keeping healthy and then also about what we were doing to keep them safe, to help reassure them. With those, we were always careful on what action we're asking them to take and when we send those out, because we know one of the downstreams is driving too much volume into our call center. We did a lot of how-to guides, a lot of educational materials in multiple languages. We were told by many it was hard for our non-English speaking patients to get good information. We've used social media quite a bit there. And then we did a lot of individual outreach. Next slide. When we thought about our patient outreach and our individual outreach, we made the decision early on to centralize these efforts. So when I said we had some staff capacity, we reached across these teams and we brought this under one set of leadership that could drive one strategy and really be constantly educating on our ever-changing guidelines, scheduling practices, and assess what patient group needed outreach at any given time. We had at one point over 55 team members who were supporting these efforts. At first, I assumed we would be outreaching almost entirely to chronically ill adults. But when we looked at our data, we realized that pediatrics was probably one of our biggest needs. We also knew that vaccine rates, not just at Erie, but everywhere, were dropping dramatically. We also happened to have a lead pediatrician who was vocal in making sure no one would forget this, which was great. And so we did a ton of outreach, personalized outreach that really scripted and addressed the specific concerns of patients. And then we had operational flows also built in to address those concerns to get patients in. And when we last audited our charts of some kids turning 4 months and 12 months, we were at about 75% up to date on vaccines, which right now is really pretty good. We've done a lot of hybrid models with that, where we offer people telehealth and then a very quick low-touch vaccine visit, so they're not really going all the way into the health center. We also did things like big test mailings and those kinds of things. Anything we could do to help people get their preventive care that they needed while maintaining everything we needed to do around social distancing and infection control. Next slide. And then finally, we realized that our patients who were, we know, so disproportionately impacted by COVID because of the structural racism that was really driving all of this, were really highly impacted by things going on also in our economy, in the larger environment, really driven by COVID, but not specifically the health impact of COVID. And that this was really impacting both our patients' health and their ability to seek care and prioritize care. And so we prioritize bridging that gap. What we did is we added a one-question screener for all of our telehealth visits. Would you like to be connected to additional resources? And almost 40% of our patients did screen positive to needing some additional resource. We had a whole team working on this, about 21 people, and they would call those patients back and do a 9-question screener about additional needs they had. And they were many. Patients averaged 2.5 needs per patient. These were hard calls. They average about 30 minutes a call, but some of them were much longer and multiple calls. Priorities were, of course, not shockingly, income-related assistance with rent, utilities. Food access became, I'm sure everyone's aware, a very rapidly presenting need, along with stress and anxiety. We were able to quickly develop a warm handoff process to our own behavioral health. We also, beyond the linking people with both enrolling in food stamps and WIC and local food pantries, we were able to partner to deliver food to about 600 of our households. And we continue to develop resources around this. We're starting a patient support fund because of this, because we realize we have to help our patients meet these needs. These, as I noted, were really long and exhausting calls for the teams, but very, very critical. And with that, thinking a little bit about next steps for all of this. The thing we're trying to figure out right now is how we maintain this. The great thing is our patient volume is coming back. We've engaged our patients and we're getting them back in. That said, that means staff are back in their home locations. They're also being pulled into testing. We have new roles like door screeners. And so figuring out how we staff this critical outreach and social determinant of health resource linkage is something we're trying to figure out right now. We're also really thinking about the change management if or when things regress back to earlier COVID stages. So we feel like we've got some good infrastructure here for engaging our patients, and now we have to figure out how to sustain this infrastructure as we move into this new normal. Thank you.
Great. Thank you, Amy. We so appreciate this information and Erie's experience and your telling of the experience. So thank you, and thank your entire team at Erie Family Health Centers.
Thanks.
So next, we're going to go into our interactive polling question number 3. So get ready to answer our polling question, which is, which services is your health center providing via drive-through setting? And you can check all that apply. So COVID-19 testing, maybe influenza testing. How about point-of-care labs? Maybe pharmacy medication refills and immunization. So which services is your health center providing via drive-through setting? And you can check all that apply. We'll give it just a moment for everyone to answer our quick poll using either your computer screen and mouse or keyboard, or if you're on your phone, you could answer it on your phone also, and you can check all that apply. So let's just give it a couple more seconds there. And I can hear someone ruffling some papers. So how about we'll end the poll here, and we'll get the responses to our polling question number 3, which services is your health center providing via drive-through setting? And it looks like 77% are providing COVID-19 testing, 16% influenza testing, 25% of health centers say they are offering point-of-care labs or testing. 29 are doing some pharmacy medication refills, and 14% are doing immunization. So some very interesting data here, and we really appreciate it. So that is going to set us up for our next health center. And we are going to travel back to Miami, Florida. And we're going to hear from Jesse Trice Community Health Systems. And Ruth is going to talk to us about what's going on at Jesse Trice. So Ruth, are you with us here?
I'm with you. Can you hear me?
Perfectly.
Okay. Good afternoon and welcome to Miami, I guess. My name is Ruth Davill. I'm a registered nurse. I'm the Executive Vice President and Chief Nursing Officer for Jesse Trice. And this is my first time being on the call or participating with the team. I apologize, I do not have slides, but I think I have important and good information to share with the team. And I've also learned quite a bit from previous two centers that gave their presentation. So for Jesse Trice, I'm going to focus on COVID-19 testing for the most part. I believe previously Dr. Lawrence gave a presentation in reference to our medical services and operations. So for community testing, just for a little background, with the initial outbreak in March of the COVID-19 virus, we immediately implemented drive-through testing, and this included walk-ups because we recognized that many of our patients probably did not have transportation vehicles. So we included walk-ups as well at only one of our locations, which was our main location, that we were providing the drive-up testing. We set up a hotline for questionnaires and screenings and scheduling of appointments. We were fortunate enough that we were able to use our school-based staff because our schools were closed. So our clinical team was able to focus on clinical services, telehealth, and trying to communicate with the primary care patients. So from March until about June 15th, we screened 3,470 people for testing. And of those 3,000, we were able to schedule around 930 appointments. At that time, we were only testing people who were symptomatic, and we were averaging about 20, give or take, tests a day. In May, we received funding of over $700,000 from HRSA for expanding capacity testing. So with that funding, we developed and implemented a community COVID-19 testing plan that had two components. One component was outreach testing and education to the community using our mobile van, and the van would travel to 3 of our clinic locations. We also continued the drive-up testing at our main location. But with the outreach testing with the mobile van, there was a significant change. No screenings or appointments were required. With the mobile van, it seems, because there was no screening or appointments, patients didn't have to be symptomatic, we immediately averaged about 30 people versus about 20 patients, 20 people a day that were getting tested. And also within probably the last 3 weeks, we have continued to see an increase, and now we are averaging about 40 to 50 people a day that's getting tested. And even one day, our highest number of people that were tested, and this is a combination between the mobile van as well as our drive-up testing. we tested about 85 people in one day. So for the total number of people we've tested so far, it's 1,900. And our calculated infection rate is about 9.9%. The Miami rate is around 25%, and the national rate is around 12%. So we're just a little bit lower than the national rate. But I also want to point out that in 2 of our zip codes within Miami, it's 2 of the highest zip codes with infection rates. So we're really glad that we implemented the mobile testing. Patients don't have to be symptomatic. They don't have to have an appointment, and they are coming to get tested. The second component to the what we're considering community testing, it involves testing of our employees. We've tested over 300 employees for the antibody, which is the blood test. And in order for the antibody test to be performed, it does require a provider's visit to order the antibody test. And we're also doing the PCR, which is the swab or the viral test. We found a couple of our staff that were positive, and they were asymptomatic. And of course, we had to go through the isolation process for those employees. The other significant thing in finding the employees that were asymptomatic, of course, one employee was, somewhat distraught and totally caught off guard, not really anticipating having a positive test result. But again, it creates a safer environment when we're able to test and find asymptomatic people, safety for their family as well as for their work environment. Now, we couldn't find any specific guidelines to indicate the frequency to test our employees. So right now we've decided tentatively to test every 2 months. So our next round of testing for our employees will be in August. And this will allow us to be able to include our school-based nurses that will be returning from the summer. And we have nurses in 40 schools in Miami-Dade County. And our next testing date will be in October, and that will be the beginning of the flu season. So maybe we'll be looking for some correlation whether our employees are having flu symptoms, COVID-19 symptoms, or just a regular common cold. And then we'll test again in December, which will be in the middle of flu season, again, looking for any correlation. And we'll test again in February, and we will be approaching the end of flu season to see if we see any patterns or any correlation with the flu or COVID-19 symptoms. We are currently in the process of purchasing the Wave Test finger stick for the antibody test. Of course, everyone is much more comfortable, of course, getting a finger stick versus the blood draw that we did initially with our employees. The good thing in reference to getting the finger stick antibody test is that we will have it, we will be able to provide the finger stick in 2 specific locations. One will be in our dental services, and prior to certain procedures being performed, the dental team will be able to perform the antibody test on the patient. And that will determine whether they should proceed with the procedure or not. We also have a women's residential facility that houses about 40 women recovering from substance abuse, and we will do antibody testing in that facility upon admission into the program. So that's my summary of what we're doing in reference to COVID-19 testing within the community, as well as for our employees. Thank you.
Great. Thank you very much, Ruth, for all you're doing in the Miami-Dade area at Jesse Trice Community Health System, and also for all the testing that you're doing. And I think your example of testing your employees is something very unique, and that's why we wanted you to talk on it. So thank you.
Okay.
So next we'll turn to our fourth polling question. So get ready for the next question, which is, does your health center conduct contact tracing for patients who have tested positive for COVID-19? So contact tracing. So yes, we have a team focused on this. Another answer would be yes, in partnership with our local Department of Health. No, this is something we are looking into. Or no, our local health department is taking care of this. So we switch over to the actual live polling. Here we go. Does your health center conduct contact tracing for patients who have tested positive for COVID-19? Please select one of the four answers there. And we'll give it a little bit of time before we get the response on contact tracing for patients who are testing positive for COVID-19. And yes, your health center is focused on this, or yes, you're in partnership with the local health department, or no, it's something you're looking into, or no, the local health department is going to take care of this. So Stephanie, why don't we turn it over to see what the results are of our poll question number 4. And there we go. Looks like the health department's got a little work to do. So the 4 answers could be, and the lowest of them is yes, we have a team focused on this. And we go up into the middle range of yes, we're looking at partnership with the local health department, or no, this is something we might be looking into. And then the largest number of respondents gave the answer as no, our local health department is looking into this. So that's contact tracing for patients who test positive for COVID-19. So great responses there that hopefully might set us up for our next health center. So Howard Brown Health in Chicago is going to talk to us about a couple of areas, maybe with contact tracing. So Willie, Eric, are you guys with us?
Yes, we are.
Yes. Great.
So I'll start us off, and if we can go to the next slide, please. So just to give you all just a example of like our idea of contact tracing at Howard Brown, we want to apply some of our practices from STI prevention. Actually, can you go back one slide really quick? And then just to give you a brief introduction of us, I'm Willie Love, he, him, his pronouns. I'm a social and behavioral research coordinator out of Howard Brown.
And my name is Eric Garcia. My pronouns are he, him, his. I'm the walk-in manager and express clinic manager for the Southside region of Chicago at Howard Brown.
Yeah, and then our project lead, Dr. John Snyder, who's the medical director at our 55th site, unfortunately couldn't make this presentation, but he has been one of the guiding factors for how we have designed this program. So next slide, please. So just walking through just contact tracing at Howard Brown, we kind of want to set up the framework of how we categorize clients that we reach out to for contact tracing. So we set it up into 2 different categories. There are indexes, and our index is an individual that has tested positive at Howard Brown for COVID-19. And then we have everyone that is a contact. So when we start off with our contact tracing, we get a list of indexes and we reach out to those indexes. And one of our big goals is to understand who they have been in contact with. And it's very important for us to conceptualize this for individuals, as being in contact with someone can mean a lot of different things for different folks. That can be a very broad term for a lot of folks. So we focus on conceptualizing this for them by saying that A contact is anyone that you have spent more than 10 to 15 minutes in close proximity with, either before 2 weeks before your symptoms started or 2 weeks after your symptoms started. And then we just want to use this little window to understand the network that this individual was in contact with. We always train our contact tracers to understand and play detectives over the phone, to understand the individual's story, understand what COVID has done to them. So the structural factors that have been lost because of COVID-19, and also just their social and individual behaviors that may have brought them into contact with COVID. So some factors that we ask over the course of a call are large social events. So asking individuals, have you been to any large social events in the 2 weeks prior to your symptoms starting? Any recent travel in and out of either the state or the country? Any social drug use as well, or even like your quarantine time length. We found that a lot of these factors, especially like large social events and recent travel, have become less common with the stay-at-home order. However, are likely to become more relevant as restrictions begin to ease. We anticipate that people will start to travel more, will start to go to larger and larger social events. I know that here in Chicago, starting Friday, we're moving into our phase 4 plan, which means that individuals can start to have slightly larger events, even outdoors. And that's one of those case studies where we'll be looking and listening very closely to over the coming weeks. Other factors that we're looking to understand over the course of a call are just clinical vulnerabilities. Do they have any underlying medical conditions like diabetes, any history of heart failure, even lung disease? So like COPD is pretty common, and and COPD and asthma. So understanding those underlying health conditions that may make their COVID diagnosis a little bit more difficult. Next slide, please. So we try to utilize contact tracing as a prevention method as well. So one of the big things about contact tracing is if you do it very effectively, once you reach out far enough in that network cluster, far enough down that web, that you can actually start cutting off transmissions between individuals. So we want to make sure that we're giving individuals correct information during this time. We found that during our calls, there's a lot of misinformation. A lot of it is fueled by social media or just conflicting news reports every other day. And there's new news every day about coronavirus, and this can be overwhelming and boggling to any individual. So we try to provide them with the most accurate information that we have at the time. We find that many folks are scared and anxious when they test positive. This also is due to factors on the news, hearing about death rates, the high number of death rates among African Americans, especially troubling at times. But also just understanding the situation that they have within their own household of COVID. Sometimes they have young kids that they fear they may have given it to, and these are concerns that we have to be empathetic and listen to their story and understand what they're going through at this time. Also, we find that when we get down to contacts, sometimes they don't want to get tested, mainly because they hear about the nasal swab being very uncomfortable. So we try to walk them through that process and, if possible, offer alternative methods of testing, if that is possible for them at that time. And this can help overcome some of those barriers that we run into. But also, we want to make sure that we provide contacts with information on proper isolation. We understand that there are multi-generational households, and sometimes there isn't a possibility to completely isolate from someone, and we have to be cautious of that and maneuver in a way that's best effective for them, and not to play a big brother over the phone or to tell them that you need to do X, Y, and Z. We try to give them the best means to to stay healthy within their own situation. So we encourage contacts to come in for testing if they have a safe way to come into the clinic. This is very important, as we find that certain contact tracing programs demand a lot of people come into the clinics. However, there may not be a safe means for them to get into the clinics. Sometimes certain individuals may be in a section of the city where the buses are completely empty and they can just take one bus ride there, one bus ride back, and never have to interact with anyone. But other times, other individuals live in more populated sections of the city, and their bus rides and even the bus stop is crowded with folks. So that's a means that we have to tread cautiously with and understand what their situation is. We do ask that all of our contacts and indexes give us symptom updates. This is the reason we ask for symptom updates, is just in case anything changes, we have 2 COVID-19 providers to evaluate and make the next appropriate action plan for them. Next slide, please. And then I'll finish this off with just how we started to train contact tracers. And then, there are a few key components of effective contact tracing. The ability to effectively communicate is very important. We always stress, Eric and I, that if you're a contact tracer on the phone, that you have to be comfortable. You have to have a comfortability speaking with folks. You have to have a comfortability with the script that you're going to be using to talk with people about not only their individual behaviors, but also their social behaviors. Sometimes, depending on populations, they may not want to disclose who the individual that they have been with, because there may be stigma based on their interactions with certain individuals. So we have to tread carefully, but we also have to have a comfortability with having these conversations. And this comfortability will be portrayed over to the client so that they feel comfortable sharing that information with us. The other part of that is like maintaining professionalism. So maintaining that professionalism, and that also means like affirming to them that their information that they're providing us is confidential. That goes a long way. That is very significant among our population and among our community members. Individuals have to be able to build rapid rapport. Have to build rapport very quickly over the course of a call. If you're going to pick up a phone call and you're going to call someone, it's really hard to like try to get them to start talking about individuals that they may have been close contact with a few weeks before, if they fear that someone may come after that individual, or that we may disclose to that individual that the individual that we just talked to was positive. We have to approach these in certain type of ways, and just being able to build a rapport makes sure that they are more comfortable giving us information. And then lastly, contact tracers have to be able to adapt very quickly to change. And this adaptation is very critical, because from the morning to the evening, information can change really quickly, and that's very key to being able to pivot on the move like that, and be able to update all new clients about any new information. So Eric, do you want to take it from here?
Sure. Thank you, Willie. So this is where I started to help out a little bit more in contact tracing with Howard Brown. Given my background with DIS, the St. Louis City Department of Health, and being a partner services associate at Howard Brown, it really gave me a leg up on how to help train our contact tracers. We noticed that our Latino community we had higher rates of infection, positive tests in our Project Vida site. So one of the things that our contact tracers were coming into, were having difficulty with, was engaging and getting information from the Latino community. As we all know, there are different factors that come into play as to why they wouldn't trust a clinical system or any other system for that matter. So as we see here in this one slide, building a rapport very quickly over the course of a call. How do we do that? So and also maintain professionalism at the same time. So these are the things that we had to adapt to quickly. All right. If we could just move over to the next slide. So one of the things we had to do was identify the primary language to be able to maintain our professionalism and be able to build a quick rapport. We weren't doing that at first. It took a little bit of time, but we ended up getting it down right. So now every patient anyone that only speaks Spanish, we're able to chart it on our electronic medical record. So when a contact tracer reaches out, we know that this is a Spanish speaker, and we're only going to assign it to someone that is bilingual. So what we do is what I did during our training, I take the Spanish speakers aside in smaller groups, and then just incorporate some of the key elements that I've learned over the time through DIS work, like such as asking open-ended questions, making this survey, this questionnaire, a conversation. It's easier to get information from someone when we have them, when they're the ones doing all the talking, and they feel a little bit more confident, especially speaking to someone in their language and using their language as well. So if someone is telling me, is using language that I typically wouldn't use, I would mirror that in a sense, in a way that is beneficial to the conversation with the Spanish speakers when they're telling me something about losing their jobs or how their work is. Like they may a lot of our positivity rates, they're coming from like their job employment. They're talking to us about things like working in factories or meat packing plants, things like that. So when they talk to me about things like that, like what it's like to be that they don't have social distancing in place, they're not providing masks, I tell them things that I can relate to, like in Spanish, like, oh, sí, mi tía está trabajando en un lugar así. Yes, my aunt works in something like that. So kind of like trying to not fully understand, but just being empathetic, like, oh, I hear where you're coming from. I've heard this before. What can we do? And we mentioned here, speaking the slang terms, we have COVID testing sites throughout the city. Some of them are mobile. Some of them are in the west side of Chicago, south side of Chicago, north side. So as we all know, there's colloquial languages and also different uses. So there's certain times when I'll use the same words that they're telling me. It may be cussing, it may be just a total slang, and it's totally fine. It does help create a better sense of communication with the index, with the patients, to get the information we need, and better assist them as well. I mean, one conversation, I was able to link one person into primary care with Howard Brown. That's just one person that I worked with, and I know that within our contact tracing, we have been able to help people, setting them up appointments for telehealth, behavioral health, getting additional resources. So all these things as we see are cultural competence statements, making sure that they're relative to the person that we're speaking with. And like I mentioned, linking them to resources, we have to have those resources available, those lists. One of the things I tell contact tracers is we know our communities so well. I know that, for example, when I'm talking to someone and I know when I verify their information, they tell me they live in the lower west side of Chicago, let's just say Pilsen area, and they're having difficulty accessing food. One of the things that I have in my resource page is I know for a fact that at 22nd and Damon, on certain days, they're distributing food. So you can go there and get food. So having those things available quickly is very helpful to our patients. And being genuine goes a long way. Like that's one of the things I tell the contact tracers is we have to highlight ourselves at the same time. Like highlighting, by that I mean we have to come across the way we speak. So if I'm asking someone to be super professional, but that's not how they speak or can relate to, then it's going to be a lot difficult for them to relate to someone. So I have to tell them, use the proper words, but also you yourself have to shine. We're going to have a conversation with someone we just met. So all that has to be a part of it, like ourselves, our self-identity. And this last one, it's okay to not have all the answers. That is super important. We are all going through these quick changes, all this information changes left and right, especially during the beginning of the pandemic. We didn't know what was going on. We didn't know how to field certain questions. And I got to the point where I just don't know the answer to these things. So It's definitely okay. Telling the contact tracers, you don't have to know everything, but when we don't know everything, one of the things is we have to be able to get those answers for our patients and also make sure that we call them back. One thing is that we may be the only person that they speak to as far as getting resources or getting tested or just health information. So we have to be able to provide as much accurate information as we possibly can. Next slide, please. So feedback from our community. Clients have consistently expressed their appreciation with having our team reach out to them and discuss their wellness and well-being first. So as soon as we start calling, our opening line, well, my opening is introduce myself, where I'm calling from and why I'm calling. And then I ask, how are you doing? How are you doing today? I noticed that you tested at this date on this date at this site. Why did you go there? How did you feel at that time? Feeling during this time, it seems like feelings are very important. We get a lot more feedback, a little bit more of a connection with someone when we start asking them, what's going on with you at this moment? We end our calls by asking the clients, what supportive things have others done for you during this time? And what supportive things have you done for others? And we have heard a lot of different responses. A lot of them are like this, the first one, friends have gone grocery shopping for me and left it on the back porch while I was homesick. So we've noticed a sense of community has gotten a little bit stronger during these times. One patient that I spoke to is this older 60-year-old woman telling me how she was maintaining her family, babysitting her family's children while they were all sick. So she had, I think, 3 kids in her home, with her grandchildren in her home. That's not usually like a thing for them. Everyone, they all live in the same building, multi-family building, different levels. Everyone in that whole building infected except for the children. The grandmother ended up getting infected as well. We tested her. I provided resources for them, and that's one of the people that we linked into primary care. Sorry for that background. It's thundering here in Chicago. There's also been an increase in spiritual support from some people's friends, things we've heard. And I passed information I received from my friend who is a doctor to an older gay couple in New York who were alone and scared and no idea what to do. And I think that's where a lot of people are. They don't know what to do. Where are we going to go from here? So this is where contact tracing has also been super helpful. What can we do? You have no idea what to do. Well, we can help you with certain resources. If you're afraid, we have behavioral health, mental health available for anyone that seeks our services through contact tracing. Through COVID testing. Same thing with food, rental assistance. We're doing as much as we can to help the community at large. Next slide, please. All right. COVID-19 social and structural factors. The key feature of our program is attention paid to social and structural factors that lead to COVID-19. As Willie mentioned, there's a lot of previous presenters have mentioned different things that come into play. Economic standing, community we live in. We know here of food deserts. There's also health deserts. There's not a lot of clinics available or healthcare available for people in certain communities. Buses may not be running, especially during these times. There's 2 different pandemics we're dealing with, this COVID, and we're dealing with racial injustice. And all those play a big role right now, where cities like Chicago there's streets that are blocked where people won't be able to get through from one end to the other, which makes it more difficult to access health. Luckily for us, we've quickly rolled out telehealth, which is now, I think, about closer to 60% of our visits at Howard Brown. Information collected on housing, employment, health insurance, food insecurity, and social support. These are things we collect from our patients. And we make sure we provide appropriate referrals. We have a whole team helping the contact tracers, myself, Willie, Dr. Hazra. There's a lot, social services. We just start referring people to better help them. We are exploring the potential of a resources first approach. Assess and provide resources, emergency grocery assistance, which is something that we're doing, and then engage in contact elicitation. So obviously during contact tracing, eliciting contacts. So the number of contacts someone has had over the certain amount of during their I would say infectious period, 2 days prior to 2 weeks before symptoms started. Next slide. As of June 16, 2020, these are our preliminary takeaways. We've had a 24% positivity rate, 2,230 positive cases of the 10,019 tests we've done. We're getting about one to two contacts through our contact tracing. The other day, as we were having our contact tracing forum, like we have a meeting weekly with our contact tracers and just going over any questions they may have, what have they been dealing with. Sometimes the other day, one of our contacts told us, I think they had 8 contacts from one person that tested positive. So that's already a huge success for us, for that person, making sure that we can get 8 people in for testing and making sure that they're okay as well. Early on, high transmission rates at large social gatherings like the Winter Party in Miami, Italian wine tasting and events in Chicago were key factors into why people were testing positive. We weren't really aware or prepared for a pandemic like this. Since the restrictions have been established, extensive transmission occurring within households with over 75% of households symptomatics or positives. We had a number of clients work in factories or large facilities with poor social distancing measures and limited PPE, as we've mentioned before. That is a big thing that we've heard. Additional takeaways. COVID-19 contact tracing is easy to do, but incredibly challenging to be effective. As any of you have had any experience with DIS work or are familiar with that, we know that nobody wants to talk to us, especially with a number you don't know. Since we have mobile testing, for instance, that's all the people would know. The last thing they remember would be the specific clinic sometimes. There's so much on people's minds right now. So sometimes just calling, and we're calling from our clinics or from our Google phone numbers, they're like, I don't know this number, I don't recognize this number, so I won't answer it. Even leaving messages, trying to get a hold of people, all those play a big role. One of the things we do tell our contact tracers during our training is you're going to get hung up on. No one's going to want to talk to you. That is very, very real in my history of DIS, in my experience with DIS, sorry. There are many barriers to providing contact name and information, particularly and understandably relevant for Latinx community. It is definitely challenging getting information on contacts. The one thing we've all heard through our contact tracers is it's easy to get through their information, why they went, like what's wrong with that specific index. But now trying to get their who they had contact with at work, the carpooling, whatever it may be, is where everyone becomes hesitant. It is such a challenge, and we're trying everything and anything to get those, be able to get people's information. Since we did have a lot of testing in the beginning, and we weren't fully established with our contact tracing, we were so backlogged. Some of our contact tracers are doing contact tracing calls for patients we tested in April, where in April, patients now they're recovered, or some of them have passed away. So it's just like, how do we deal with this? How are we able to get this information at this moment? And one of the things we have said, as long as we get information on the index, the person we're calling, the patient we're looking for, that is sufficient. We're definitely trying to get contacts, but if we don't, it's definitely okay. We want to make sure that we still reach the people that have tested positive and get help to them as well. Time to contact tracing initiation is critical to limiting onwards transmission. It is very true. We're trying something. We're going to start trying something new. Where we try to get information, contact tracing calls out to people that are presenting symptoms at our tents. So if someone comes in, let's just say right now, 2:30 at tent at 63rd Street, and they have a fever of 100 degrees, or they're presenting with headaches, body aches, then we'll notate their information and get all their contact information, get them tested, and before we know they're positive, we'll have a contact tracer call them, making sure, just following up on their symptoms, see where they think they may have gotten it, and then just follow up with the results. Transmission events are occurring within first day of symptoms, which is often before test is obtained. Let's see, many community members are struggling with core resource needs, and contact tracing is less of a priority to them. Engaging people with what they need and are concerned about what can help improve our potential impact. Willie, do you want to follow up with that? Or not? All right.
Can you hear me?
Yes.
Okay. I was struggling with that there. So many community members are struggling with core resources, and we say improve our potential. So one of the things we're trying to do is make sure that we're addressing the needs that the community needs. We're addressing community needs. A lot of communities have different needs right now, and it's important to understand those difference in needs, and also understand that their situation, like contact tracing, isn't at the top of their priority list. It's understanding that sometimes food or even job security or even housing security is more important to them. So speaking with them about those issues can also bring about better results for us than to try to push contact tracing as what's most important for them. I think this goes back to what we were stating earlier. We don't want to act like a authority figure in these moments. We want to make sure that we're addressing the community where they're at, and that we're being an asset to the community more than a hindrance. We do not want to go in and say you need to do X, Y, and Z because we're contact tracers on behalf of the health department or on behalf of our health clinic. We want to make sure that we're approaching the community in a respectful way, and we're addressing their needs, and their needs are more important than what we feel with contact tracing at times. So that's very important to keep track of during this moment. As Eric can probably attest, a lot of our contact tracers, they can lose sight of this idea that contact tracing isn't the most important to the individual that you're speaking with at that time. And you have to find out what's most important to them, address that, and then possibly move on to contact tracing.
Slide.
Great. Well, I want to thank both Eric and Willie. We really, really appreciate your lessons learned at Howard Brown Health from contact tracing. It's something really on the forefront there. And I want to thank your team at Howard Brown. Make sure you thank David, Magda, and Kristen. And also I want to thank all of the other speakers. Phenomenal presentations today. Phenomenal work. It truly amazes us at Health Choice Network and Alliance Chicago, all of the work that's being done at the health center level. And as our 10th webinar comes to a close today, we want to look to the future for better together, innovating now for tomorrow. Alliance Chicago and Health Choice Network are going to be co-sponsoring our annual conferences this year. With COVID-19, we have elected to not have an in-person conference. However, we are going to have a conference that everyone should attend. It'll be in fall 2020, and we're going to be together. So better together, innovating now for tomorrow. More details to come on the joint Alliance Chicago Health Choice Network conference, all virtual. So again, on behalf of Alliance Chicago and Health Choice Network, my name is Tim. I want to thank you for joining us on this series throughout this period. We will be having more COVID and beyond webinars. We'll probably have one in July, yet to be determined the date. But we want to thank you for your interaction today on what aspects of the new normal am I looking forward to. Some great things: hugging my family, family reunions, patient engagement, seeing old faces again, virtual care, innovation, being in the office. And as always, I hope everybody smiles. We have to embrace change and we'll grow together. So once again, on behalf of Health Choice Network and Alliance Chicago, thank you for joining. Have a great day, everybody.